Hi, everyone. We're going to go ahead and get started. All right, so we have two wonderful presenters, Dr. Perez and also Diana, that'll be talking to us. She's a mom. Sorry, I don't have much background, but they're going to share a whole bunch of great information with us, okay? And then afterwards, we'll open it up for Q&A. All right, so get away.
All right, it is very good to be here and very good to see all of you. My name is Dr. Angel Perez, and I work for the University of Florida under a grant program called the Florida and Virgin Islands Deafblind Collaborative. So we cover both the state of Florida and the Virgin Islands. What we do is we provide technical assistance, training, professional developments, networking, almost anything you can think of around a child birth to 21 with both vision and hearing loss, so deafblindness. My background is in visual psychophysics from the University of Alabama in Birmingham. So it is a pleasure to be here. I am not a formal person. I do a lot of speaking, but I do a lot of appealing to parents because usually the doctors that are in already know the stuff. So I try to explain the information and help any way that I can with the parents. Okay, is this on? Oh, okay. So now that I've got this figured out, is everybody in here familiar with cortical visual impairments? Yeah, pretty familiar? Well, my information may not be anything new, but you're welcome to ask any questions that you'd like. So what is it? Well, CVI is a brain-based visual impairment, and it's caused by the damage or dysfunction of the brain's visual pathways. So back here is your occipital lobe, and your ocular system is sitting up front. And there's an optic chiasm, there's a crossing there, and the pathways are in the back here. And usually that is where the incident occurs for CVI. It's common in genetic disorders. Some of them are rare, idiopathic GRI disorders. And I say they're common in genetic disorders, and I did use the word rare, and I say that because, and I have to kind of smile about that because right now, the Florida and Virgin Islands recognizes 81 common genetic disorders, but we treat all of them. We work with all of them. So I have genetic disorders that don't have a name yet, but that always astounds me when I say 81 common genetic disorders. Common, like they make it sound like it's an everyday thing, which it's not, but they do make it sound like that. Okay, so how is it different from an ocular impairment? Well, you've got your eyes, right? And the system is all mechanics up here, but the light comes in from wherever. This light back here is coming in. It's bouncing off of whatever I'm looking at and sending the signal to the back of my eyes, to the retina. That's where the brain begins to start working. And the image is actually upside down, but our brain flips it upright. I'm sure everyone's heard that. And so when you have an ocular issue, it's usually something that is wrong with the mechanics of the eyes. So it could be something like amblyopia is brain blaze, so that's not a good example. But you can have things like myopia, hyperopia, astigmatism, things like that are some probably familiar terms that you're used to hearing. And those are some things that you can have wrong with the mechanics of your eyes. But CVI is a different thing. It's a brain-based thing. And it's actually still not as well known as we'd like for it to be. It's not recognized as well as we'd like for it to be. Usually if you go to an optometrist, most of them work on the mechanics of the eye, so they're not familiar with CVI. And a child with CVI can potentially pass a visual acuity test, but still not be able to see. And that kind of throws the optometrist if they catch it. But most of the time, it takes someone like a neuro-ophthalmologist or a neurologist, someone like that, to be able to look into that and to diagnose it. And I've even talked to ophthalmologists before, and I've said, do you understand or do you deal with or work with children with CVI? No. Why? It's too complicated. Too complicated for us to deal with, so some actually, okay. Hopefully nobody's coming through there in a minute. But anyway, so, some of them feel like it's too complicated even for them to deal with. And so they want to pass it on to someone else with, more neurological training. All right, so what causes it? Well, I have a whole host of things here that cause it, but this is just a tiny little list of what causes it. You have complications from premature birth, epileptic seizures, genetic conditions, lack of oxygen, pediatric and prenatal, perinatal stroke, traumatic brain injuries. Let's stop and think about traumatic brain injuries for a minute. That covers a lot of territory, right? So if you're looking at this list and you're seeing some things, some of these are genetic syndromes, Down syndrome. You have CHARGE syndrome. Anybody in here have a child with CHARGE syndrome? Yeah. We love those babies. Those are some of my favorite babies. And they're all my babies. So you have, in some very rare conditions, but let's go back to the traumatic brain injury for just a second. That encompasses a whole lot more than just genetic syndromes, right? So does that mean that CVI only occurs in children with some of these disorders? It can happen to the average person. So stop and think about what a concussion is. A concussion is a traumatic brain injury. So I've always often wondered what these professional football players might have been seeing. You've heard of a few of them who have had so much traumatic brain injury that they've committed suicide. And I've often wondered, could they have been experiencing some of this and not understood what it was and thought they were going crazy? So I've always wondered about that. How prevalent is it? Well, CVI is extremely common, yet remains widely undiagnosed, which makes no sense to me. As a matter of fact, the National Eye Institute is now coming around to CVI, and we're hearing more about it from the National Eye Institute. 5 years ago, not so much. So one of the studies, there's a study that we have that shows that 1 of 30 kids may have CVI-related difficulties. There's several studies that show that up to 70% of children with cerebral palsy have CVI, and 64 of the kids with CVI have epileptic seizures. Sorry, my tongue is tied today. 72% with developmental delays. Autism. Some people don't think that autism would fall into that category, but it does. It absolutely does. And then 20% of genetic anomalies. Okay, so functional vision and brain. So the functional vision is how a person uses their vision in everyday life. So TVIs will do functional vision assessments on children if they suspect a vision impairment, or if they already know that the child has a vision impairment, to see how their vision is functioning in the daily life at school and in that atmosphere, so that they can get an idea of what type of recommendations to make, maybe to the general ed teacher or the special ed teacher or some of the therapists that's working with the children. Visual processing involves multiple brain functions, including attention, memory, sensory integration, motor planning, and emotional regulation. As a matter of fact, there are 17 visual activities that you would need to be successful, that you would need to have intact to be completely successful, like in school or college, anything like that, at a job. 17 different types of skills. Individuals with GRI disorders, these are areas often compromised, affecting low visual information. Disruptions in communication between visual pathways. So if you think about that for a minute, this disruption does happen. And I've seen videos and I've talked to children who have CVI, those that are not nonverbal, and asked them, what is it like? It's like swirling colors of just disformed type colors, and they're just kind of melting together. It's very difficult with depth perception. So we've had children with cortical visual impairment who, I had one young lady who, when she would get up to go to she would sit at an 8-foot table with other students, and when she would get up to go to throw something away, instead of just getting up and going straight to the trash can, she always made her way around the table with her hand kind of touching each of the chairs so that she kind of felt her way there. That was her routine and her way of understanding where she was at. Individuals with, I've already said that, disruptions in communication between the pathways. That is exactly what that's like. So, difficult to interpret visual scenes. I always think about, where's Waldo, right? Where in the world's Waldo? That is something you would never want to give a child with CVI. Anything that's that busy. OTs use a lot of different types of therapies with children in schools, and so they'll use these different types of patterns and things to use with them. Well, with a child with CVI, some of those very, very busy patterns get very upsetting very quickly. It's visual noise. They can't concentrate. They don't see what's there. As a matter of fact, it looks like a big old blob. Okay? Recognizing objects and faces. So, if you have a child with CVI, it's likely that there's a range of CVI, and it goes from 0 to 10. And if the child is on the 0 to 3 range, it's very highly likely that they may have visual agnosia. Does anybody in here know what that is? That means you don't recognize faces. So I've had moms and dads be very upset because the child didn't recognize their face. They could recognize their voice, but they couldn't recognize their face. And then, of course, difficulties navigating environments. If you have objects that you're trying to present to a child, they don't need to be busy. They need to be very, very simplistic. If you had a child with CVI looking at a book, it needs to be a picture book with one picture on it. We have all these children's books and they have all of this embellishment all over them. That doesn't work for a child with CVI. Busy rooms with, you go into a classroom and all of these decorations are around. Usually those kinds of things will cause a meltdown. Understanding functional vision from a neurological perspective is going to be the key. That is the key to understanding what meaningful supports you're going to give that child. Okay, so how is it diagnosed? Well, this tells you a whole bunch of stuff, but I'll just be right honest with you. How it's diagnosed is usually it's going to be done with if you can find a ophthalmologist that will treat or recognize children with CVI and understands how to test for that, or a neuro-ophthalmologist. Your optometry, not so much. I have it there, but not so much. You have a few that are now beginning to learn, those that are working in pediatric optometry that are just beginning to learn what that is. But it's usually a very specialized career field person that can do that. We also have TVIs that are changed. So TVIs, teachers of the visually impaired. We are now training teachers of the visually impaired to recognize it. Can they diagnose it? No way. They don't have that capability, but they can. They know the signs and they know what to look for. So it is changing. The Eye Institute and the National Institutes of Health have begun to identify CVI. I think it was last year that I sat on an 8-hour at home, it was a remote webinar for 8 hours with NEI, trying to learn more about it and learning more about how NEI is actually beginning to finally recognize it, thank goodness. Okay, so some of the common CVI behaviors: difficulty with visual attention and recognition. They have a hard time recognizing things. Visual attention. You want the child to look at you, they don't want to look at you, they want to look over here. Or you think that's what's happening, right? You think they're being, they just want to ignore you. They don't want to ignore you, but they don't see you. And so if they're on the lower end of the range, they're looking around you. They're looking all around you. Sometimes it looks like they're looking through you. They have trouble using vision in cluttered and crowded places, taking them to a shopping center, taking them to a football game where they would have to look up into the crowd and things like that. Those are very busy things that usually become disturbing to them. Difficulty with hand, foot, and eye coordination, obviously. And there's 10 characteristics, and one of those is visual guided reach. So if I were going to reach for a cup that was sitting on this podium right now, I would just reach for it, right? But it is within our habit or within our abilities to just reach for that cup, but we're looking at it, right? Children with CVI will turn and look all around as they're reaching. They don't look right at it. And children who have CVI on the lower end of the range usually have trouble with things like central vision. So they're looking peripherally in their visual fields. And then they also have problems with distance vision at times. So the child may not be able to see more than a few feet in front of them. So it just all depends. If you've got a child with CVI, you've got one child with CVI, because it is very different for each one. But these are some basic characteristics that actually happen. I had a little boy one time go and hang his coat up on a hook in a classroom. I went to observe, and he seemed fine. He went across the room, hung his coat up, and stopped dead still in his tracks and slid down the wall and sit. And he wasn't going to move, because that was the safest place he could be, because instantly when he turned around, he was unable to see anything or to make sense of anything he was seeing, let me put it that way. They struggle to perceive motion. They have trouble with facial recognition, so that would be visual agnosia. They experience visual fatigue very often. So they have to have multiple breaks all throughout the day if you're working with a child like that, because they do struggle with fatigue. They have difficulty interpreting pictures, words, symbols, anything two-dimension. So if you're working with a child with CVI and they are on the beginning stages or the lower stages of CVI, you want to try to use 3D symbols for them. And use some tactile tactics in with that, and letting them feel things, and trying to work with them and talk with them. This is a spoon, those types of things. But they need that singularity, and they need high contrast around it to be able to visualize it as well. They have trouble integrating vision with other senses. Hard time finding things at a distance, difficulty navigating from place to place, like I told you about the little girl. That little girl that went all the way around the table, by the way, we took her out one day just as an experiment to see how it would affect other areas of her vision. And when she tried to walk from an area that was brick into an area that was concrete, even though it was flat, she would stop dead still. Okay, baby, we got to go a little bit further. I can't. Why not? Because I'm going to fall in that dark hole. That's how she described it. I'm going to fall in that dark hole. So she was terrified. We never could get her to cross the threshold. And so visual field loss. Sometimes they'll have visual field loss, but they do use that peripheral vision close in, usually, if they're on the lower end of the range. They'll use that visual, they'll use their visual field, but it is up close. Okay, what are some common visual characteristics? Novelty, difficulty. So anything new, especially if it's a toy that's got a lot of different colors on it, they're probably not going to pay it any attention. You know, even if it doesn't upset them, they're just going to ignore it. Movement preference, they love movement. So if anything that you can get that you can move across the table, they like to watch fans. They like to watch things move like that. Visual reflexes, distance difficulty, and visual guided reach, which I explained earlier. Color preference, let's talk about that in a minute. Never thought I would see anything like that, but most of the children who are newly diagnosed and are on the beginning, or on the, I call it the beginning, but it's the 0 to 3 end, red and yellow is their preference. They don't like blue, they don't like green, they don't like purple. You think they don't like it, but the problem is they don't see it. So the reason they see those yellows and reds is because it's on the infrared spectrum. And so on the light spectrum, so they can see those better, so that's what they're going to choose. They love Elmo or, you know, the little yellow duck, but they don't like that muted purple plaything that you might hand them, or something with multiple colors. Light gazing. Light gazing is another big thing. They love to stare at lights. They will go to the window and stare out the window so that they can stare at the sun or toward the sun. They love to watch the light. Field preference, again, they will use up close visual field. Visual latency. So they see it, but they're not processing it, so it takes them a little time to figure out what they are looking at, even the simplistic objects. And then complexity issues, they have a real issue with complexity items. Okay, so how does it impact? Well, here's you a list, but it basically impacts everything, right, folks? It's going to impact their daily living. It's going to impact how they socialize, communicate, their motor skills, their academics, health-related, quality of life, and mental health. Again, back to the football player who I've always wondered, did he have one too many concussions, develop CVI, and just didn't know about it? Didn't know what it was, couldn't figure it out. Oh, I'm going crazy, this can't be. Complexity in GRI and CVI, overlapping symptoms complicate visual access, most definitely. Now, since we're talking about that, overlapping symptoms, can a child with CVI also have an ocular disability? Or is it singular? You either have one or the other. No, you can have them both. So now we have doubly impacted that child's ability to function and have good quality of life, because now they aren't seeing, they're not processing what they're seeing, and they may not even be seeing really well anyway, depending on what their ocular diagnosis is. Behaviors may be misinterpreted as cognitive or behavioral disorders. The first thing that somebody wants to do, usually in a school system, when they run across a child with CVI and they don't know what it is get them a behavioral specialist. Let's call in the behavioral specialist. They've got it. They don't have it. They don't understand it. If the behavioral specialist doesn't know what CVI is, they're going to try to use tactics that they would use on a child with autism. Does that work? No. And I'm going to tell you why it doesn't. This child with CVI is not acting out because they want to act out. They're not acting out because they have some type of disorder like autism that may be prevalent in their diagnoses. They're acting out because they're frustrated. And the videos that I have seen of the reenactment or the simulation of what it would look like, that would cause me to act out too. I just can't imagine what it would be like. Oops. Okay, so misdiagnosis and misunderstanding. CVI is often misdiagnosed as autism. Just talked about that. Let's go get an ABA therapist because they're going to know what to do with this child because we don't know what to do with them. They're acting out, they're having fits, and we don't know what to do. Well, you have to understand the child and what's going on with the child first before you know what to do. Don't make assumptions. That's one of the worst things you can do is just assume, well, this child's just a behavior issue. Not true. Global developmental delays. Importance of proper assessment in GRI populations. We definitely need. I can't stress the importance enough of having the proper type of assessments for children with GRI. Okay. Developing comprehensive therapies, so addressing the vision, communication, and motor needs. So you have to look at the child holistically. We can't just look at one thing. It's not a one symptom thing and we can fix it because CVI can't be fixed, like it can't be cured, but you can make their vision better. There are ways that and strategies that can be used to make their vision better. They call it CVI range for a reason, so it's 0 to 10, but as they progress, they can get a little further up the scale, and their vision can get a little bit better. Team-based and personal-centered planning usually helps. Okay, and here are some resources for things that you can look at for CVI. These are all wonderful resources. A lot of them are from Perkins, but you can also find things from Dr. Roman Lindsay. You can also find things from Ellen Maisel. You can find things from the Texas School for the Blind. So these are all really good resources, and what these resources do is to help you understand the child a little bit better, what they're experiencing, and what are some strategies? What are some things that you can do with the child? What do they like? Again, we can go back to those 10 characteristics if you think about it. And that's something that when we assess a child with who we potentially think has CVI, we look at those 10 characteristics and then we assess that. You know, I may take around different things like colors, novel toys, getting reactions, seeing what they do with movement. Children with CVI love shiny things. So like light gazing, they will also gaze at, you know, glittery things. They love bubble towers. They love those Mylar balloons and the pom-pom things with all the, you know, the ones that you can get at the Dollar Tree that are really, really shiny. They love that kind of stuff. And you can really watch their vision abilities by maybe dimming the light a little bit and using some of these objects. So those are the biggest part of my talking points. Again, I am from the Florida and Virgin Islands Deafblind Collaborative. And you are welcome to contact me, and I'm happy to also answer any questions that you might have. I usually try to appeal to my parents and leave a lot of the technicality out, but if you're interested in that, we are absolutely open to any type of discussion. And now I want to turn it over to Jennifer? Diana. I apologize. I don't know why Jennifer's on my mind, but Diana. Thank you, Diana.
So, hi, my name is Diana. I have a son who's 6. His name is Jack, and he has Grin 2B. And we recently, last year, moved from Mississippi to San Antonio, Texas. And a little background about Jack is he was born very early. He was born at 25 weeks gestation. I had him because of preeclampsia. And we stayed in the NICU for 144 days. In that time, he was intubated for 70 days. He was oxygen dependent. At one point, he was on nitric oxide, jet vent, oscillator, all that stuff. We knew once we were discharged that being on oxygen for that long, and then he came home on home oxygen as well, and was oxygenated for 2+ years after that, and then COVID hit. So we knew that being there was risk being oxygenated that long could affect his eyes in some way. But we had never heard of CVI. We had no kind of understanding or idea of what that could mean or be. So as he got older, and he also has epilepsy and polymicrogyri. He's got microcephaly, epilepsy, so he runs the full gamut. So in the grand scheme of his life at the time, no offense to him or the CVI community, but his eyes were not really on our, huge to-do list to kind of maintain. But, he was not acting, any type of way. They had checked his vision and said that he could see, and they checked his hearing and everything like that. So, fast forward to when we were kind of noticing things about him was he started having nystagmus, and so the shaking of the eyes, he would have one eye that would turn in, not together, but yeah, so he would have one eye that would turn in, and then the other eye would turn in, but not typically at the same time. And so that's when we took him to the ophthalmologist. Now, I have no idea how they got his prescription the way they did, because it took 3 nurses and myself to hold him down to get his eyes dilated. And the doctor in Mississippi was like, yep, he needs glasses. So no mention of CVI at that point, and he was probably 3, maybe 3.5. And so we got him glasses and we went on about our lives. It wasn't until about 2+ years ago that we went to a therapy center in Austin, and it's called Napa Therapy Center, and we were talking more about it, and I was looking actually more about it online with other parents, and they were explaining to me about CVI and like what it looks like and how he looks at things and stuff like that. And we had noticed him only wanting things close to his face. He would literally bend his whole body to put something close to his face. That was the only way he would be happy if his show was on or whatever. And we just thought, okay, maybe he was just seeking stimulation that way or what have you. But then we kind of were like, okay, let me dive deep on this. So that's whenever we were talking with other providers and friends and Facebook groups, and finally we were like, okay, I think he has CVI, and thinking this is probably what's going on. And we finally found the right ophthalmologist that could finally give us that kind of diagnosis. And he also, when he was wearing glasses, he would look like this. He would always look out of his glasses like a grandpa, I'm like, what are you doing? Yeah. So, and they kind of explained it to us like that's the only way he probably knows how to see. He and sometimes he'll look out of his eyes like this and turn his head and look that way. So even with his glasses on or off, he'll look that way. So, so we went to the Napa Center, and I'm sorry if I'm jumping around, but we went to the Napa Therapy Center, and at that moment, they had actually built a CVI room to do therapy there in the room, and it's pitch black, and it is lit up with like lights and like there's like sparkle lights and beads and toys, and they have like a big board that has a push button that has, and he loved it. He thrived in that environment, and it was so monumental to see him actually doing the therapies that he needed to do because he was in a space where he could see. And it was frustrating because, we had bought all the toys and done all the things that we thought we could, he could play with and pat. Obviously he had other developmental issues, so we knew, it wasn't going to be what we thought it was going to be, but, now we recognize what it looks like, how he acts, and what he needs. And so we put the books, like you said, the books need to be basic, one shape, one color, nothing like that. I mean, he has a whole shelf full of books that he don't care about. I bought out Amazon basically for those books, but yeah. So it was a very kind of crazy process to get to the CVI diagnosis. And right now he still wears his glasses every day, that we don't lose them. And then, like I said, he kind of looks down and looks like that. So yeah. Trying to think of anything else. I don't want to miss anything. Oh yeah.
We do have about 10 minutes left of the session, so
Okay, good.
perfect timing.
Good.
It was like you knew.
I know.
It was like you knew. So yes, and for those online, please submit your questions online. We're keeping an eye on those too.
So did the story that she just presented to you sound pretty much like everything I was telling you in the presentation? It all lines up. It all completely lines up. The thing is that we need more research, and we need more people interested in CVI and wanting to do the research and wanting to learn more about it, instead of, we always want to focus on, can my child see? What is their visual acuity? What is their visual acuity? Well, visual acuity is really important, but it's not the only thing. We have to focus on every aspect of the child's vision. One of the things that we're doing now is developing a program so that we can test babies' vision birth to 3, because not too many people do that I know of. You can get a newborn hearing screening, but you really can't get, an eye screening that early in life. And so we've developed, some tools and things to go in and be able to do that. My question to you, Diana, was, did he have other ocular issues? Did he have retinopathy of prematurity from all the oxygen and?
Yes, he had ROP. Yeah, sorry, he had ROP, and that, honestly, they didn't really kind of go into further detail about that. And so it was, all right, he's got ROP, he's probably going to need glasses, and, like everything else when it comes to rare disorders and our kids, it's kind of like, well, we'll see you at your next checkup and see how it goes. So, yeah.
Okay, I have just a comment and then a question. The first comment is, when I heard you talk about visual attention, it made me think in grade school, almost every test that's taken, even for kids with special needs, the bottom line is there has to be visual attention, but yet they don't record or consider. If the child's looking around, they consider that just, it's wrong.
Exactly.
But it's so important for people to be trained in that, especially in those early primary grades. But the question I wanted to ask you is CVI therapy, if that's what it's called, is that the same thing as a developmental optometrist? Because in California, we have a bunch of those, but they seem a bit different than what you're talking about.
They are different. Developmental optometrist, they are also holistic. They also look at, so one of the things that we're looking at is not just the visual acuity, but the child's visual behaviors. And their motor skills, their gross and fine motor skills, all of these things kind of play into developmental optometry. It should also play into CVI, but they are a bit different. And again, a lot of times your optometrists are not real familiar with CVI. And so they're looking for, by looking at their behaviors and their motor skills, they're looking for an ocular issue. Can the baby pull up on the, if the baby pulls up on the couch and he's 14 or 15 months old, and you can look at the child's face and you know they want to let go and walk, but they just won't do it. Is it a cognitive issue? Is it a motor issue, or is it a vision issue? Usually vision is the last thing people think about. But we're hoping to advocate that people look at that a whole lot more.
We were very, very lucky. Tristan had an exceptional pediatrician who stayed with him until they threw him out at 22, because DuPont wouldn't let her keep them. He was sent to a neuro-ophthalmologist when he was 6.5 months old, because once he started having seizures, she wanted him to be checked for everything. So much of what you were saying is true. Tristan has only ever worn red Chuck sneakers because those are the ones he picks every time he goes to the store. It's really difficult to find places. He had vision therapy from Overbrook School for the Blind when he was a year old, but they were working more on his visual acuity than the recognition of ocular.
They were looking at ocular.
Right.
I have done some work with Overbrook School, and so yeah, they were probably looking at what can we see from the ocular aspect, and it didn't go any further.
I will tell you though that I think even the ocular therapy very early on helped his ability to address his vision from his point of view. He had strabismus surgery when he was...
This is the eye turn, when the eye turns in, out, up, or down.
Yeah, so, no.
I'm sorry.
He had that
yes.
He had that surgery very early on. So we've been very lucky to have a physician who sort of quarterbacked his program and got him where he needed to go really, really early.
That's awesome. So when she says strabismus, she's talking about an eye turn that goes when your child has an eye that turns inward or upward or downward or outward. We're talking about strabismus. They have specific names like esotropia, exotropia, but if you hear the term strabismus, that's what it is. And they do have to, if it's severe, they do surgery on it because it's a weakness of the muscles around the eye.
Okay, so we've got 2 questions online. One of them is from Chris. Let's see, I don't have my readers on. I'm showing my age. What advice would you have for parents of nonverbal children who may suspect their child could have CVI, but are finding it difficult to convince providers to consider neurological issues with eyesight and not just anatomical?
Okay, so one of the things that I would recommend, because sometimes it is difficult for providers to find a provider that actually does recognize CVI. They can actually look at, now they, obviously we're not going to get a diagnosis from themselves, but there are some things that they can do themselves to see if they think CVI is actually the issue, such as dimming the lights, trying out all these different shiny things, addressing novelty versus something that they're familiar with, color. They can look at these 10 characteristics and be able to come up with simple things that they can look at. And then once they do that, then they need to seek someone out that does recognize it. Now, you're going to have some ophthalmologist and neuro-ophthalmologist that actually advertise. We have two at Boston Children's Hospital that do research on CVI all the time. You need to find someone then. If you can test that child for some of those characteristics, and anyone can do that, then that's when you want to seek out someone that will really listen to you.
I was going to say too, just like piggybacking on what you were saying about you had a really great practitioner. Now that we're in Texas and it's really, really important, I didn't know what a TVI was. I didn't know, that there was anything that you could do that, where a teacher could be for the vision in the school. But they came to our house and they walked with Jack and I, like I pushed him in the wheelchair, and she would notice when the cars would go by what his head would do, what his vision would do. We walked down the street and there was this big blank space between the trees, and it was really dark. And so he immediately turned his head that way and stared at it and like would not move his head. So it was just very, very, I'm very thankful that we have that now and we're able to get that. So it was definitely something to push if you don't have that. Yeah.
Appreciate that. We've got 2 more questions.
Look for resources too, like Dr. Gordon Dutton, who does Scotland CVI, and then Dr. Christine Roman Lancey here in the United States, and they have a lot of information on their website, and they also, Dr. Christine Roman Lancey looks at children with it.
That's great. That's great. I've got 1 more online and 1 more in the room, and we're running close on time here. So the one online from Karen is, my daughter uses a speech generating device, an app on an iPad, and has a recent CVI diagnosis. Is there any research on CVI and screens that would guide us in settings, positioning, or other modifications to help her see that screen better?
Do you have something? I do, yeah. Okay, so both of us have an answer for that. They do have a lot of information and research out there on CVI and AAC devices, which is what she's explaining. And Dr. Roman Lancey talks about it. Dr. Gordon Dutton talks about it. There's a young man in New York who does a lot of work around CVI. He works in the New York school systems. His name is Chris Russell. So you can look for these folks and they can tell you, or look for their research, and they can tell you a whole lot about AAC devices. I could go into it more, but I know we're limited with time.
I was going to say too, we started, and I know I bring up Napa therapy a lot, but it's been very, very incredible for us in multiple ways. But we started AAC therapy at Napa, and they saw that he had CVI, like on his diagnosis, and he when he went in there, they turned off the lights. They put his eye gaze device. We started trialing an eye gaze device, and it was incredible to see because I mean, like having developmental delays and seizures and stuff like that. You never know what is going to happen and what he will and won't do. But literally just seeing him being able to raise his head and actually move the button and do that intentionally because he can see it better now is wonderful. So if you have that ability, because we were like, well, he can't see, he's probably not gonna be able to talk to us, like how is he ever gonna be able to do that? So, but never count Jack out is, like, what am I thinking? And so it was just an amazing thing. So if that is something that you are worried about, I would say keep trialing, keep pushing for that, get that in the school, because you never know what it can do, like really, really, truly.
I'll make this as quick as I can. My granddaughter is on the severe end of Grin 2A. So she has multifocal epilepsy, which is very severe. She has a ventilator on and a feeding tube, and she cannot sit up, cannot hold her head up. They diagnosed her with CVI. as well, but she's severely cognitively disabled as well. So I guess my question is, and it kind of goes back to what you said, the vision wasn't on the top of our list because it was really about her being able to breathe that was at the top of our list at the time, and the seizures. So I guess we're in this quandary. She's 4 years old. We don't know how severe the CVI is. We don't know what kind of therapy would even be beneficial for her, or what when we're trying to determine the types of therapy and the OT, the PT, and the things that she needs to survive, like, this may seem like a weird question, but like, where does CVI therapy fall in that list of priorities, and how is that going to help her with her quality of life? Do you understand kind of where I'm coming from with that?
I was going to say that's exactly what my husband and I were talking about. When we would go, because Jack, he can't grab anything. He's not going to push a wheelchair. He'll never be able to do that. We have to do everything for him. He cannot do anything. But persistence is what helps and what keeps it going. So when they suggested doing the eye gaze device, we were like, well, but there are kids in there that go to this therapy clinic and they don't do anything. But they've got an AAC, and they have been doing their work and eye gaze and everything like that, and they can have full sentences. Now, they've been doing it for 6 to 8 years, but this person this child who's a quadriplegic, who has trach vent, G-tube, it happens. It can happen, and I know that's, like you said, it's not on your radar. It wasn't on ours. Like, we were like, okay, if he's not having a seizure, okay, we're good. We're going to get through the day. But if you keep at it and keep going and pushing and finding resources around you that can do therapy like that, it's a game changer, really is.
So to answer your quality of life question, the difference that this would make in this child's life is, if you think about it, and when I was describing some of the simulation of CVI, the swirling, nothing makes any sense. If you have someone that can do these therapies with the child, the difference is going to be, can I recognize your face now? Because can we get them from 0 to, say, level 5 or 6 on the scale, and they may not can do anything else, but can they recognize your face? Will all of these, things that they are having difficulty processing actually start to have some type of meaning? It helps with their ability to communicate in some form or fashion. It's going to help them, their quality of life, by their mood. It's going to make the world's going to, that type of therapy helps the world make sense to them. Whereas everything makes sense to us. We look around, we see whatever we want to see, we know what it says, but they have no idea what they're seeing. So if we can get them in that therapy and get them moved up a little bit, then it will increase their quality of life by the world around them making some kind of sense, because right now it doesn't make any.
Yeah, that's exactly.
Yeah. Well, I appreciate it. We are right at time, but thank you both very much.